All right, good evening, everybody. Welcome to the Ask the Experts hour on the periarticular knee session of our osteotomy course. This is an internet live session being presented by AO North America. This is our faculty for this course. Mike Miranda could not make it tonight, and so we've got Brett Christ also helping us out, along with Mauricio Kafuri and Tim Weber. This is the disclosure information for all of us that we showed last week as well. This session is being recorded. If you don't wish to have your image or voice on, then leave the sound off and leave the video off, and then that won't be an issue at all. The copyright statement is that all rights for the educational resources and assets used and owned by AO North America and the AO Foundation and all its contributors are for educational purposes only. So recording or copying any aspect of this is strictly prohibited. I'd like to remind everybody of Zoom meeting etiquette. At the start of the meeting, the host will mute all your microphones and turn off videos of all the participants except for panelists and presenters and moderators. In the dedicated chat feature of the meeting, please use the Q&A function. This worked really well on Saturday, and you ask questions, and we'll be monitoring that. We'll try to bring your questions up. Brett Christ will be looking at that, and he'll bring it up to me, and that way we can really get a good back and forth going, even though we have a large number of people involved in this session. The learning objectives at the end of this session, we hope you can list all the indications, or some of them at least, for periarticular knee deformity correction, and also non-union management, and also the deformity correction techniques for extra-articular alignment, as well as for intra-articular osteotomies. The faculty and topics on last Saturday, I'm going to spend a few minutes here summarizing and going over things again. Those of you who were with us on Saturday, hopefully this will remind you a little bit and refresh your memory, and any of you who won't, this will be new. So our topics include distal femur extra-articular deformity, and that was presented by my partner at Missouri, Mauricio Kafuri. Then we had distal femur intra-articular deformity, and that was presented by Mike Miranda, and Mike again couldn't join us tonight, but I'll go over some of the points from his talk. Then on proximal tibia extra-articular deformity, I gave that presentation. And then finally, bringing up the rear of the caboose was proximal tibia intra-articular deformity, and that one was done by Tim Weber. So first, I'd like to summarize a little bit Mauricio's talk on extra-articular deformity of the distal femur. And he started out giving us a little bit of the history of osteotomies. And I guess this slide really caught my attention because this patient and surgeon who did the first one did it with no anesthesia. And I've had a distal femur osteotomy, and I tell you, it was a big procedure with anesthesia. So I'm very impressed, but I think Mauricio said they did it in like 5 minutes or less. So I suspect that guy was really having some pain for a few moments, but it was a very interesting history he told us about first. And then he started talking about distal femur osteotomies. And he noted that for treatment of a valgus knee, it isn't always a distal femur osteotomy. So here he's showing a valgus knee, but if you notice on this plan, yes, the lateral distal femoral angle is off, but the medial proximal tibial angle is very significantly off. And so if you only treat the lateral distal femoral angle with a femur osteotomy, thinking if it's valgus, it's got to be femur, you're going to end up with a bad situation. And so this is an example of that pre and post-operatively on that patient. So again, this is an example of a valgus situation, and that this patient already had a total knee on the other side, and they needed a total knee here, but they had a bad joint with bad alignment. So it was going to require a constrained revision type total knee prosthesis. So instead, what Mauricio did in this case is he realigned them first, got their weight-bearing line, as you can see, where it belongs, and got their angles correct, and then came back and did a total knee with a prosthesis that would be like you would use for a primary. So it's a very interesting use of osteotomy first to correct. Then he went into the discussion of single cut osteotomy, what I was taught as a resident, versus the concept of a biplanar cut. So single cut, you're just one straight cut across here. Biplanar, you've got about 2/3 to 3/4 of the way across the bone the same way, but then this long biplanar cut here that you see. And he pointed out a lot of points about that and some of the advantages and disadvantages regarding stability, more rapid healing, and some things like that. His third point looked into whether you should do a lateral opening wedge versus a medial closing wedge if you're doing a distal femoral osteotomy. So you can see the lateral opening wedge on the left, and then you can see they've cut out the bone, and then they're doing a closing wedge on this one on the right. And he notes the lateral opening wedge is easier to perform, but there are a lot more hardware complications with the iliotibial band snapping across the plate, and there's just not as much soft tissue cover there. On the medial side, the medial closing wedge, much faster healing because you're pulling it together, but it's technically quite a bit more demanding. So there's pros and cons to everything. You want to get good for sure at one of them. Ideally, you learn how to do both of these and do what works better for that patient. He noted for his take-home messages that distal femur osteotomies have almost 2 centuries of history. Currently, we have much better understanding regarding the plane of the deformity, the 3 dimensions of it, bone healing, and the stability of the constructs. He noted biplanar cuts give you a broader surface area, less harm to the extensor mechanism of the knee, so much less risk of cutting into that as you're cutting across. Closing wedge techniques are inherently more stable and they heal more quickly. Distal femur osteotomies do not apply just for valgus deformities of the knee. You can have it for tibial varus as well. And so it's, or for varus, not tibial varus. And I showed a case of that in my talk. And then corrections are possible in the frontal, sagittal, and axial planes. Next, Mike Miranda went into the topic of intra-articular malunions. And he noted that you can have clinical problems in these cases with pain, stiffness, instability because of that intra-articular malalignment and step off, as well as deformity. And this listing, he gave Joe Schatzker, as well as Mauricio Kafuri, a lot of props for this talk, that they both really helped his understanding of this. And Joe kind of adapted, this slide's adapted from his teaching. And he noted radiologically, you get joint incongruity, malunion, bony demineralization as the patient just won't walk on it because of pain, and then varying degrees of osteoarthrosis. So here's an example. This problem list shows a patient with epiphyseal malunion with a step off, and you can see that right here. Right here. And then a metaphyseal non-union, osteoporosis, defects from previous implants, varus alignment, and then he's got this step off in the joint right here. The knee was also synovitic. The patient wouldn't move it, had tremendous pain. So to successfully address all that, you need to be aware of the pathology and the cause of the variance from normal. You need a technical skill set, so you need to know if this is a case you can handle. If not, get a friend to help you. Knowledge base, information, anatomy, etc., principles in the management, and then finally, the right resources with implants and tools. Then he really talked about, and again, this came from some teaching from Joe Schatzker, applying the principles that restoration of articular congruity is critical where possible. Restoring normal alignment may require you unloading a malunion and then maintaining blood supply and compressing the articular surfaces. And here he really talked about the impact on articular cartilage when you have significant step-offs and when you have don't have an anatomic reduction and absolutely stable fixation, which is what you need. So it starts to really impact the cartilage. The scientific basis for intervention he presented, which was the role of mechanical loading of the repair cartilage and bone, the biomechanical and metabolic changes in the cartilage, the role of inflammatory cytokines, and the viability of the chondrocytes after traumatic injury, all can contribute to the progression of post-traumatic arthritis. And he noted a case, a study by Furman et al. In Journal of Orthopedic Trauma that kind of backed that up. Next, he talked about approaches that you have to be able to visualize in order to do this. He talked about lateral, he talked about midline, he talked about the tarpo a lot as a great option if you really need to see the joint, and then the medial approach. And one point he really made was if you're going medially, be aware that the blood supply isn't as good and that the key parts of the blood supply tend to be posterior. So you don't want to strip too far posteriorly. There is a safe zone available that will allow you to lift up the VMO and get to this, but you have to understand this anatomy and apply that understanding carefully. Again, the arterial supply on that medial side is primarily just from the superior medial genicular artery. The lateral femoral condyle has broader supply with both superior and inferior lateral genicular arteries. So be careful with the medial work. You've got to use really good technique in order to make that work well. Finally, the medial femoral condyle malunion in the coronal plane. You have the intra-articular corrective osteotomy can prevent poor outcomes, and technically it's very challenging. It offers a good outcome and is a salvage treatment. In the cases of impaction or cartilage loss, if it's pure depression or impaction and healed, it's extremely difficult to raise that and graft it and have that cartilage survive. In young patients, you may need to either do a large allograft or an Oates procedure like what you see here. An extra-articular osteotomy is necessary in order to unload the damaged area. So basically, Mike's final points were early intervention for intra-articular malunions is critical. Vascular supply to the distal femur is robust except medial femoral condyle. Goal of the intervention is a stable joint without shear or articular step-off. And elderly patients may be better off with an arthroplasty. Next, we went over to my talk, which was on the proximal tibia extra-articular deformities. And my goals were for you to learn some of the indications, to understand that it is not always a tibial osteotomy for a varus deformity. So the same idea as Mauricio, but on the opposite side of things. I also talked about why would you use a biplanar osteotomy in the tibia, and then some surgical tips and tricks. So first, on the indications, many of the things in the course up to our session had to do with obtaining union or correcting bad rotational deformities. On the extra-articular deformities for the ones around the knee, it's often about trying to basically unload the joint and preserve the joint in patients with post-traumatic osteoarthritis to hopefully buy a significant amount of time prior to them needing a total joint, or hopefully maybe even putting off their needing a total joint. I then talked about that, again, you need to plan the cases very, very carefully. And I showed this case with a gentleman that had had significant trauma from a military injury much earlier in his life, supracondylar femur with an arterial injury at the same time from a mortar blast. He had bilateral varus, but the right side is what hurt him by far. He was absolutely set that he would not have a total knee because his wife had had one and had severe complications. And so he had this very bad post-traumatic lower extremity 25 years after a supracondylar femur fracture. You can see how far off he is there. It's really impressive. And this guy's active on this despite, so you've got to plan it. And this is one Mauricio and I worked on together. And in this case, to get him where he needs to be, it really requires a double level osteotomy, a lateral femoral closing wedge with a medial tibial opening wedge. And that's what it came to look like. And this guy has done quite well. He was way too active and actually broke his tibial plate and lost about half his correction on the tibia. But the femur was really stable right away because of the type of osteotomy we did, and that healed beautifully. And he is still going on this with no total joint, and he's very active as a consultant in the special operations community. So it just shows the importance of planning. And then the whole concept of, if it's in varus, like what you see with this patient, does that mean it's a tibial osteotomy, which is what I was again taught during my residency. And what you see here, this is the planning software we use at Missouri. And just to orient you here, this patient's in varus, it's their left knee. But when you look, their proximal tibial angle is normal, it's 87.1, but their lateral distal femoral angle is very abnormal at 97.3. So what this patient needed, even though they're in varus, is they needed a femoral osteotomy with an about 11 millimeter cut in order to then get their lateral distal femoral angle to 87.3 and their proximal tibial angle to 87.1. So we basically can balance it beautifully if we can do that cut. So this software lets you plan it out, play with different cut amounts, and get different angles, and it works out really nicely. So this is what it looked like afterwards. I added the second plate because I cracked the hinge, and so I added a second plate because of that. So don't create a joint that's oblique with the floor. Planning's critical. And then the whole idea of the biplanar osteotomy and the rationale behind that it improves your ability to adjust corrections in both coronal and sagittal planes, better stability due to an increased surface area up here, just like what Mauricio showed in the femur, and it's quicker to heal also for the same reason. So we really picked a lot of the same things. It works for both the tibia and the femur. And I've gone to nothing but biplanar osteotomies. That shows you what it looks like. Finally, I went to some surgical tips, and just a couple to remind you of is that you want to have an oblique orientation of your K-wire right to the tip of the head of the femur. Don't cut the lateral cortex open it very slowly and progressively. There's multiple osteotomes in the set that's designed for this that you can get that has the Tomofix plates as well. So if you sequentially place the 5 one after another, it slowly will open it up, and that lets the bone not crack. And then finally, we talked about breaking around the hinge, like what I showed in the femur. And basically, if you break into the tib-fib joint, you usually don't need to plate that. You might go a little slower with your weight bearing, though. On the other hand, if you break above the tib-fib joint, like I see here, that one you need to plate in order to maintain stability. And then if it's the distal femur, usually you should plate it if you break the hinge, like what I showed before there. So again, my teaching points for the indications often involve joint preservation. Varus does not always mean high tibial osteotomy. There are advantages to biplanar osteotomies, and then surgical tricks of opening the osteotomy slowly. Grafting, you don't have to. It'll sometimes speed their time to weight bearing though, and then breaking of the lateral hinge is something that you want to treat. Finally, Tim went into the much more difficult in many ways topic of intra-articular deformities. And he talked a little bit about a big matched cohort study with over 8,000 patients. And that patients who had intra-articular step off that was left were 5 times more likely to need a total knee than a matched control group. The results of this were a mean of 13 years. And 2, this is another study. 2 went on to early fatigue, 2 had severe progression, 4 slight progression, and 15 no progression after proximal tibia varus osteotomies. So 74% after these had excellent results that bought significant time, 13 years or more. Variables that affect the outcome on the knee are mechanical alignment, joint congruity, orientation is important, and then meniscus, because meniscus covers 60% of the contact area and can transmit more than 50% of the total axial load. An unstable valgus knee with loss of extension, you need to watch that sagittal plane and look where it is as well. Don't get sucked into only looking at the coronal plane. Be careful of this, because that's really where the bigger deformity was. So Tim's summary and take-home points were that we can take advantage of many factors specific to the knee joint. The literature will support you if you choose to reconstruct the knee, and the technique is demanding but very doable. The recurring themes you saw during all 4 talks were the cartilage is very important, and it's all about protecting that articular cartilage and avoiding post-traumatic osteoarthritis. Planning is critical. A stable joint with appropriate alignment is absolutely necessary, and there are many technical tips that you can learn in all 4 of these areas. So that's a quick run through what we did. I'm going to stop sharing now and have Mauricio Kafuri take over, and he's going to run through the first case for us. And then we've got about 40 minutes left. That took about 20 minutes, which is what I'd kind of planned. He will run through a case, and then I will come back and run through 2 more if time allows, but we want to make sure we do these right. So Mauricio, if you can take over and run through your case, and then we'll go from there.
Thanks, Jim. So let me share my screen. So
just remember, if you have questions, make sure you go through the Q&A component of Zoom, okay, for the participant.
Okay, so this is the first case of the night. This is a patient who is 49 years old. He came to me because of right knee pain. He's a very active individual with tricompartmental knee arthritis and a history of a femoral fracture more than 30 years ago. This is how he presented to me. I'd like to ask my panel, what would you like to add in terms of comments? What do you see in those pictures? Jim, Tim, any comments about those pictures? He's a 49-year-old male that was told that he would need a total knee replacement, and he has significant pain in the knee.
And to me, his joint spaces don't look bad, Mauricio, and it's not a knee that I would think automatically would need a knee replacement at 49, which is very early and leaves him at high risk for wearing out that knee early because of his young age. It looks like he's got a sagittal plane deformity as much as anything else here, where they didn't get it really aligned quite right, and it healed, but he's got an apex anterior or flexion deformity of the femur, for sure. Proximal tibia doesn't look real bad, and that is the biggest deformity that I'm picking up.
Absolutely, I agree. So
It looks like there might be a little bit of varus also.
yes, you're absolutely right.
Distal femur.
You're correct. You can see he has a distal femur malunion, as you pointed out, with the varus and apex anterior as well. And most of his pain is medial. In the clinical presentation, he has varus. He has no torsional deformity. In his range of motion, he lacks a little bit of extension, and he has 105 degrees of flexion. He has a varus thrust, which is very easy to identify when he walks, and he has no instability regards the cruciate ligaments.
Mauricio, do we have any long leg alignment type films?
Sure, here we go. This is what you see. Any comments on that, Jim?
Yeah, good pickup on the varus for sure. So you do see there is a significant coronal plane aspect to this as well. But again, I think it's important not to forget the sagittal plane aspect, because it would be easy to potentially just hone in on this, and I think we'd want to be careful about watching that. So that's more varus than it shows the importance of these long leg radiographs for everybody. And one of our participants asked in the Q&A if we had the long leg. That wasn't my brilliant thought. That was what I saw in the Q&A from one of the participants. But
yes,
it shows just how important that is, because it was picked up, but it wasn't nearly as obvious. Here he's got a huge amount of varus, and so it's really important both to have dedicated films around the knee, but also to have these long leg standing films.
Team, when you look at this particular long leg standing X-ray, what else can you pick up? What else is very evident to us besides the varus?
That is, it appears as though he's got a little bit of a limb length discrepancy, that he's short on the on that affected side. I'd also like to just sort of emphasize what Jim has already said with regards to his joint surface looks good. And, all too often, the response to knee pain is we should replace the knee joint. And there's a lot of other solutions. The knee joint is actually quite resilient. And I don't think we need to be as nihilistic with regards to the knee joint as oftentimes is in the.
Guys, there's a couple great points on the Q&A. Itamar De Palma wanted to know how we would evaluate rotation in this case, and that's very important. We've talked about sagittal plane, we've talked about coronal plane, we haven't talked about that. And then Joe Schatzker's on, and Joe is making a comment that sagittal plane deformity is better tolerated in the femur than the tibia. In the tibia, it's really critical. In the femur, not as critical. Joe, thank you for that wisdom that we can pass on to everybody.
So as to add to the torsional aspect of the deformity, I always perform a clinical exam to evaluate the rotations of the hips and to make sure that I have a very good clinical picture. And in case I have any kind of discrepancy, I go for CT scan.
Mauricio, can you describe your exam? Do you flex the hip 90 degrees and then internally, externally rotate, or what's your exam of it?
Yeah, my exam is with the patient laying down, and this has been very well presented by Mitch. When we go and rotate the hip internally and externally, and we try to compare to the opposite side, we also pay attention to the progression of the gait and make sure that there is no component coming from the tibia. And then this is the way I normally take into consideration for evaluations of torsion. And if I have questions, I go for CT scan to have a complete.
Mauricio, you are doing it in the prone position, right? As far as hip rotation,
yes,
for torsional evaluation.
Correct. Prone.
Okay.
Correct. Then this is how we apply the software now. And when you see the software can give us a lot of information about where the deformity is coming from. Any comments from you guys when you look at those pictures?
Yeah, so I'm not nearly as smart as you with these, but you've taught me how to at least get a little bit of ability to perform these and read these. And right away, I always am honing in around the knee, even though there's, first thing I guess I would say, Mauricio, is I see nothing but red on this picture, so that's not good. Because red means it's, if you use this particular analysis software, red means it's abnormal. So there's virtually nothing normal in this extremity is what it's telling us first. But I'm always focusing in first on the lateral distal femoral angle and the medial proximal tibial angle, and they're both abnormal. The medial proximal tibia is much closer to normal than the lateral distal femoral, but they're both abnormal.
Yes. And one of the things here that is critical to pay attention is that this patient has 15 degrees of varus. And if you look, as Jim pointed out, all his joint orientation angles are completely abnormal, meaning it's a very complex deformity. You have to figure out where the 15 degrees is coming from. And if you look to the MPTA, it's 84 and normal is 87. So it's just 3 degrees off apparently from the proximal tibia. It's a little more coming from the distal femur. And if you look that he has a malunion in the distal aspect of the femur, you're going to say, well, probably I have to address this deformity going direct to the femur where he had the original fracture.
Mauricio,
So,
I have a question for you.
Yeah.
Do you have an amount? So you pointed out the proximal tibia, if we're just honing in on these two, proximal tibia is only off by about 2.9 degrees or so from an acceptable number, whereas the distal femur is off by 12. Do you have an amount where you would say, rather than do a double osteotomy, if it's within 1 degree, 2 degrees, 3 degrees, I'll leave the tibia alone in this case? Or if it's abnormal, do you, how much are you willing to accept to not have to do a double level osteotomy?
So it all comes to the final planning and to pay attention if the joint is parallel to the floor or not. So I always do simulations above and below the knee, and I see how the joint looks like, if the joint is parallel to the ankle or not. Because the critical point here is not just to shift the mechanical axis to the neutral point, but also to keep the joints parallel to each other and parallel to the floor. And this is why most likely you try to bring those angles close to 90 degrees.
And I want to make sure everybody's really, because I'll tell you, in North America, when I trained, nobody talked about this. And I can't tell you how many oblique to the floor joints I think have been created by people just doing a single osteotomy, no matter what. If they're in varus, you do the tibia. Look, in this case, this person's in varus. And if you did a huge osteotomy in the tibia to get that Michelitz line where it belongs, you would have a horribly oblique joint. And that would make the total joint later terrible, and the patient would do very badly. So I think it's a really important point for everybody to, if you leave with nothing else from this section of the osteotomy course, know that you can't make oblique joints and expect your patient to do well. And that means you must plan. And if you can get the nice computer software, that's great, but you can measure it all by hand if you have to.
Absolutely. So then this is to show you the big picture of this patient. These are the radiographs, the AP and lateral views of the knee. This is the long leg standing x-ray, the angles measured. And now we go for a simulation just to be on time. And this is exactly what Jim mentioned to you. If I think that the only source of the problem is the femur where he had the fracture before, and I go for a major correction at the level of the femur, you see I can bring the Michelitz line to the neutral point, but I can have this varus corrected. But again, the lateral distal femur angle is abnormal and my proximal tibial angle is abnormal. And pay attention to the obliquity of the joint line, as Jim pointed out. It's a critical thing. You can always bring the Michelitz line to the center of the knee, but to the expense of obliquity of the joint line. And this is what you don't want to have. You don't want to have a knee which is not parallel to your ankle, and you don't want to have a knee that's not parallel to the floor. And this is the critical point that I'd like you to follow, because as I said, it's not about going to one level. Sometimes you have to simulate and see how the joint looks like.
Mauricio, we've got a couple, and I love to do an online chat. And so we got a couple of questions. One was, what is the software? It's called Medicat. It was developed by our German colleagues.
Yes.
And then someone wants to know if not only the coronal, but some oblique plane and rotational deformity, how does the software marking and measurements of the angles work? So maybe you can describe a little bit how you handle the complex rotational deformities as well. And then someone asked, do we have a long leg standing lateral? And I don't think we do in this case, probably.
No, we don't have a long leg standing lateral to present here, but I looked at this picture as well. I had the long femur to measure the deformity or the curvature of the femur. And in terms of torsion, this software allows you to measure the torsion at the same time, but you have to enter the CT pictures of the patient. So you have to collect the CT, and then you should enter some specific cuts of the CT, and then you can measure the torsion. And again, continuing to be on time, this was the plan. As Tim pointed out, this patient had a leg length discrepancy, which was not huge, but it was something that was really bothering him. And then we ended up with a plan that was, how can we normalize the lateral distal femur angle, the proximal tibial angle, bring the McCulloch's line to the center of the knee, and try to bring this an improvement in the biomechanics here. So this is what we've done with the software. How many millimeters? You need a calibrated image so you can know exactly how you translate your degrees into millimeters.
Mauricio, a couple Q&A questions real quick. One is, if up at that original, if the ankle line is not parallel to the ground, and that frequently is the case in these people who have big time malalignment, what's the preferred reference for the knee joint line to decide if it's good? And I will tell you, with this software, you go down and you map out the ankle as well, and then it maps it all out for you. But maybe you can answer that. And then Itamar asks, if available 3D printing, would that help with planning?
Yeah, 3D printing I use especially when I have intra-articular deformities. This helps me to understand intra-articular deformities. And what I try to do is to bring the knee angles or the joint orientation angles of the knee close to the 90 degrees and using the normal reference values for those angles. Because sometimes they do have issues with the ankle and also with the hip, but I try to bring this knee parallel to the floor. And this is how it looks like to me now. And this is what we ended up doing. You see the femur has a curvature, but when you go and you see to do the biplanar cut, you can see on the lateral view was not an easy biplanar cut because of the curvature of the femur. I had to follow the curvature of the femur to end up with a biplanar cut, because I always do biplanars, open and closing wedges, to have a broader surface area. And here you can see the comparison. Now you have a joint which is, you have a lower extremity which is aligned, and the angles are corrected. And the leg,
if you look down at that ankle, it's also better now. So once you get the knee right, the ankle often is now oriented horizontal to the floor as well.
Yeah. So any comments from you, Tim, or Jim, so we may continue, Brett?
I think it's a beautiful case. Did you make any attempt to correct that? I think you did, but it was hard to tell for sure with the pictures, to correct the sagittal plane deformity on the femur, because I know you can with the biplanar, you can correct it some.
I would say at the level of this osteotomy that I ended up doing, I didn't go exactly to the site of the malunion. You see it's a little above.
A little higher, right.
A little higher. So to go there, I would have to use a different technique to correct this deformity. And as Joe Schatzker pointed out, the femur accepts very well this kind of deformity, sagittal plane. And if you look at this femur, it doesn't look too bad. And I have another picture, which is a longer picture, the long femur, that really doesn't have a lot of curvature.
So Mauricio, in the chat, we've got another very good question that I'd like you to answer because it's important. On this double level case with medial arthritis, why not overcorrect to the lateral spine rather than just go right down the middle?
Yes, I appreciate this question very much. Thank you. This is a good point. I mean, to me, there are some guidelines on where to bring your McCulloch's line. You can overcorrect, but then you have to figure out that you may end up with abnormal angles. I could have done a little more for the femur for sure. My concern is always to have abnormal angles that may compromise a future knee replacement in the, later on. And this is the main reason why osteotomies are not very well accepted, maybe in many places, because sometimes those joints were corrected to the point where the knee replacement became a very complicated procedure just because of the obliquity of the joint line.
Another great question. Mark, don't hesitate to ask him. I love you, Dominic, because we really would rather have your guys' questions. He asked, can't the tibial osteotomy correct some slope to help this patient achieve full extension?
Oh, absolutely. In this case, you can see that it's possible because it's a biplanar that you can come with a lamina spreader to the back of the tibia, another lamina spreader to the front of the tibia, and you can easily play with the slope. I didn't mention in this case, but I played a little bit with his slope in order to know how much. I normally have a K-wire coming from the front to the back parallel to the original slope of the patient. So I see during the correction on the lateral view how much I open and how much I angulate my K-wire. And I have a sense, like by 5 or 10 degrees, how much I can correct this slope. It's a good thing of biplanar, and this is a good plus for biplanar. It helps to correct the sagittal plane as well.
So another question, and I did note this on the original things. The patient has some patellofemoral arthritis as well. So we got the question of, is there any additional assessment you want to do for the patella in this case?
Well, in the radiographs, absolutely correct. But this patient didn't have a lot of complaints coming from the patellofemoral joint. This is the reason why I didn't address it.
Great. Joe asked, what influence in decision-making is the chondrocalcinosis?
I would say it's an important information to have. But I would say to me, for this particular patient being 49 and being an individual who is very active, even if he would have significant chondrocalcinosis, I would still try to pursue this kind of correction.
Okay, we're getting a great chat going back and forth with people. Another question is, could we do a distal femoral dome osteotomy with the proximal tibial osteotomy?
We can do a dome osteotomy. Dome osteotomies I prefer to use when we are dealing with translational deformities. I prefer this better. And I've done some cases where it was a complex deformity with a component of translation, and it works very well with translation. More often I'm used to do those closing or open wedge biplanar osteotomies around the knee.
Sure. And Mark Sanders asked, when does one go to the distal anterior cut? Mark, are you asking about when does one do a biplanar on the femur? Or I'm not real sure what you're asking there. And while Mark maybe answers that, someone else said, thanks for this amazing work. The question is about the approach. Mauricio, you use only one, the Tarpo approach, or separate approaches for the tibia and femur. What would you do? One approach, multiple approaches to get to the femur and tibia? How do you approach it?
In this case, I did 2 approaches. I did the proximal tibia approach, and I did the subvastus for the distal femur. And the subvastus is a very straightforward procedure. You just have to lift the vastus medialis from the femur, and then you have to protect the neurovascular structures in the back by having a retractor posterior to the femur. And by doing that, you're absolutely safe. So 2 incisions, 2 medial incisions in this case.
And when you do that subvastus approach, it's very important your soft tissue handling. It can really make a huge difference if you do it well. Another question, do you use the osteophytes as bone graft in the osteotomy site?
I normally don't.
Yeah, I don't think the quality of osteophytes is good. I don't think you want to use those for sure.
So
okay.
just to summarize the message about this case, I appreciate all your questions. So varus deformity does not mean that the correction is at the level of the tibia, as has been presented multiple times during this course. A malunion site may not be the only one to be addressed in a lower limb deformity. It's not because you have a malunion that this is the only site that you have to correct, especially if this is a 30-year-old deformity. You may have other things going on, and you have to have the complete evaluation and assessment of the lower limb. And to me, double-level osteotomies have been a big change in my practice since I started to understand the importance of the joint orientation angles and how to keep the joint balanced. not compromising or harming future surgical procedures for these patients.
Mauricio, another question is, if we do the osteotomy planning in a long leg standing radiograph, and we use intraoperative fluoroscopic imaging with the patient lying down on the operating table, how should you aim the center of the knee for the Micklitz line if the patient is not standing while using the alignment rod? And I'll throw my comment and then I'll let Mauricio. The alignment rod with a patient laying down is extremely inaccurate. It's better than nothing, but because they're not standing and you can get such changes depending on the rotation, it's very, very, very inaccurate. And so that's why the preoperative planning is so critical, because that it will allow you to, if I've preoperatively planned and I've done exactly what that computer preoperative plan or hand preoperative plan showed me, and then the alignment rod doesn't look quite right, I'm going to trust my plan, not the alignment rod. Mauricio, what do you say?
So I would say the same. I trust my preoperative planning because it's based on x-rays that were taken with weight bearing. And normally I like to make sure that I double check this preoperative calculation more than once. And I try to reproduce the same number of millimeters that I calculated before. But I always tell my patients, and I'm very transparent in this regard, that we may be off by 5 degrees eventually, because sometimes you have some things that could happen during those procedures, especially with close and wedge, that you may be a little off. I don't recall cases that I had to come back to redo because it was not acceptable, but I had cases where I was not completely spot on, and the patients understood because I told them ahead of time.
Yeah, I had one in clinic today that's a very tough one that Mauricio and I are planning and going to do together. I told them the same thing, that it may be a little bit off from what the perfect plan is. I think that's important to let people know.
With regards to intra-op, I agree with you, but I also think there are certain things you can do. Like on your standing alignment view, your patella is right in the center of your condyles. And so putting your patella in the center of the condyles when you're in the operating room can improve with regards to rotation.
Yeah, one of our viewers just put that same thing up in the Q&A. Agreed.
Yeah, and then making sure the knee is fully extended, and oftentimes just making sure that if you're using the Bovie cord, that you have it up off the limb so that it doesn't catch on the limb.
Yes.
If you're using a rod, that's different, but if you're using a Bovie cord, it needs to be high enough so it doesn't catch on the limb and give you a false reading. I got one question, if I can. Beautiful case, and when you say we might be off by 5 degrees, that's what impresses me about the courage that you going after the tibia where it's 3 degrees, and still you're willing to do that, and we need to have that courage based on the preoperative plan. I think that's super important. I'm just curious as to where I'm sure you mapped out different options beforehand, being tempted to try to correct more limb length by translating that distal femur laterally, letting it slide down that oblique osteotomy and try to gain more length there.
Yeah, I've done, thanks for your question, team. I've done multiple calculations for this patient specifically. And to be honest with you, sometimes I spend almost the same time in the preoperative time than I spend in the intraoperative because there are too many calculations to be done. And it's a lot of fun, to be honest with you.
That software lets you simulate, and he showed it quickly, lets you simulate doing a double osteotomy, trying to do a single and what would happen. And he showed the single left you with a problem. And so you can simulate all these different things on the computer, which is really helpful.
And one thing that in this case, he had an MPTA of 84, but I didn't correct to 87. It's possible to take your MPTA up to 92 without a big issue for the joint line. So some people say you can go up to 94. I don't like to go to 94 for the MPTA, but 92 is very reasonable sometimes. And this is why you have to play a little bit with the numbers, and you have to be in a kind of range which would be safe and acceptable for the patient.
So another question, I hope everyone's okay with, I'm kind of making a moderator's choice that I'd rather answer the questions and get everybody out there participating than do another case. And so we've got another question that is, if this patient had a symptomatic patella baja, what's the treatment? And would you add an additional tibial tubercle osteotomy? And I will tell you that patella baja is one of the really difficult things to deal with around the knee. And I often do a tibial tubercle osteotomy as part of treating that. Guys, what do you think?
So patella baja is challenging because when you do open wedge tibial osteotomies, you may also make it worse. And patella baja could be a relative contraindication for open wedge osteotomies, especially if you go above the tubercle. And this is why some authors go below the tubercle in order not to make it worse. So this is why you have to have a complete picture of the patient and to see if this is a patella baja. Sometimes if you do your calculation and you open a wedge like I've done, you may make it really worse and you may have to really go below the tubercle.
And then would
Mauricio, how would you?
Oh, go ahead, Brett.
I was just going to ask, so how would you plan that with your biplanar osteotomy?
Then the cut goes descending. The cut goes descending. So you're not going to go above the tubercle, you go below.
Okay, another question is, would fixation at the medial level of the distal femur be feasible with a non-locked plate?
It is feasible, everything is feasible, but locking plates for this particular procedure, they add a lot of stability to the construct. And some people don't have access to the particular plate that we presented here right now. And some of my colleagues are using proximal tibial plates to fix the medial aspect of the femur, because the fixation of the medial aspect of the femur is still a challenge. Even for trauma, we don't have great implants for the medial aspect of the femur, but it's possible to use. I've used angle blade plates, which is my favorite kind of implant, the 95-degree angle. In the past, these were the implants I had available for the medial aspect of the femur. Yes, it is possible to do implants that are not locking plates.
Okay, got one more question here real quick. What is the limit of proximal tibial lateral opening wedge regarding the possibility of perineal nerve injury by stretching it?
It's a good point. I mean, I don't have a number to give you. I don't have this number to say. I don't know if there would be a very specific number, because I imagine it has to do with the patient size, etc. I really don't know if there would be a number for that.
Okay, and then another question is, if the opening wedge distal femoral osteotomy was also sliding, then the hinge was cut. Should 2 plates be used?
I would say I didn't have the impression that in this particular case I presented to you, we had a compromise of the hinge. If you see the cut, it goes up to here. And this is another good point to show you guys. You see, this is the projection of the lateral cortex, and this is the projection of the condyle. So this is where you want to aim your osteotomy. You go very low, and this is why I like to go biplanar, because you can do a biplanar cut and your main cut is going to go under the trochlea, which allows you to go to the metaphyseal area where you have a very good bone healing. Yeah, and I don't see that I compromise the hinge here. This that you can see here right now is the biplanar cut.
Yeah, if you go that low in your oblique, you run some risk of maybe running into, on that lateral side, the trochlea. So yeah, I think the biplanars are really worth doing. Mauricio, Joe Schatzker has a comment that without locking, when you do an opening wedge, you have to put a spacer in the gap.
I completely agree with Joe. And also I would say, if you go without locking, there is another trick that I learned from my mentor, Kleber Pacola, that was used always to have a screw, a percutaneous screw, securing the hinge, coming from proximal to distal. And he has published this technique. not only for the distal femur, but for the proximal tibia, which is very, very ingenious. If you don't want to use a plate on the opposite side to protect your hinge, you can come with a percutaneous screw just to secure your hinge.
I
So
think
Mauricio,
Mark's
yeah.
point,
Oh,
I
I'm
think
sorry.
Mark's point may have been that if you're trying to get length as well, and you did a sliding osteotomy with the hinge breaking, should you always double plate? I think that
Oh,
may
yeah.
be what he was getting at.
Okay, so now I understood the question much better. So in this case, my plan was not to promote a big lengthening coming from the femur. The only lengthening that happened was related to the opening of the wedge. I didn't do a sliding osteotomy in this case, but I agree with Mark that if you have the complete osteotomy, it's better to secure the opposite side.
Yeah, I was going to say, and Mauricio and Tim, correct me if you disagree, but nothing is always hardly in orthopedics. But I've learned the hard way by losing it that if you break the opposite side hinge on the femur, you really should think hard about doing another plate. Again, if you break above the tib fib joint on the tibia, same thing. If you break into the tib fib joint, that adds stability, and you often can then be okay. Do you guys go by those same rules, or do you feel differently?
I agree with you. And this is why tibial osteotomy should be always aiming the tib fib joint, because the ligaments of the tib fib joint are going to protect your hinge.
Okay, a really good question that's on here that I want to make sure we get to before we run out of time, which we are. And again, I hope everybody's okay that we only did one, but we're answering all these questions, is how much lateral bone should you leave? How far over should you take the hinge and not break it? And is that amount over the same for the tibia as for the femur? And I'd love to hear from both Mauricio and Tim.
Let me, Tim would like to go first.
No, I was going to make a comment that I think that we can also create some stability by loading our fracture or our osteotomy. And so once it's positioned, as long as we don't lose alignment by going ahead and loading it, I'm not totally committed to putting a second plate on all the time. I think we can create some stability in that fashion. You know, I guess it depends a little bit on how much correction we're trying to gain. The more correction, the more I think we have to get closer to the far side. But trying to leave, getting up to the cortex but not through it, and then just going really slow so that it bends more than breaks. It's hard to be patient sometimes in the operating room, but it almost never doesn't pay off.
And a very important thing, I would say, if you notice that your hinge is broken and that you have a displacement of the opposite cortex, especially if you're doing an open wedge technique, it makes it very unstable, inherently unstable. And you may end up with a secondary loss of your correction eventually. So I agree with Tim said that you may load your osteotomy. We normally do with a proximal screw, which is a cortical screw that's going to load the opposite cortex. But we should be absolutely convinced that the other side has some degree of contact, or you're going to be very unstable. And I've seen this happening. As far as how long the osteotomy should be, I try not to go more, I try to stay kind of 1 centimeter away from the cortex for the distal femur. I do the same thing for the proximal tibia. 1 centimeter is a kind of very arbitrary number, but this is a kind of number that I use. And the other thing, which is a critical thing that I'd like to share, when you go with your K wires that are going to give you the direction of your osteotomy, try to use another K wire to measure how deep you are with your guiding wire, because this gives you a good sense about how deep you should go with your saw. So I use my guide wire as a depth gauge, so I know how deep I have to go, and then I don't have to be concerned with my saw going there. And normally if you have more than one K wire, you have to measure how deep is this each wire, so you know exactly how deep you go with your saw, and most likely you're not going to have a hinge fracture. I don't recall the last time I've seen a hinge fracture, just by following those basic rules.
So a management of a hinge fracture on the tibia that goes into the joint, someone asked about, what do you do with that? And the answer is it's a small plate, but you need to get a plate over there if it's going up into the joint. Make sure the joint obviously is reduced. We are, I'm very sorry to say, running out of time. This is great. There's a couple more questions. Someone asked to use arthroscopic treatment in combination with, and I sometimes will look to make sure that that the joint is reasonable for an osteotomy, that I don't have really bad grade 4 tricompartmental all over, or if there is something like, say, a meniscal tear that you can treat at the same time, so that you don't have them walking around on something like that can be a pain generator at the same time. And then indications for bone graft or bone substitute when you use locked plates. The truth is it will heal without doing that, but when you do that, it probably heals faster. And so I like to throw in some bone marrow aspirate concentrate and some cancellous cubes to let my patient weight bear earlier. But the truth is it will heal without doing that, and that adds some money. And so you don't have to, is bottom line. This has been a great discussion. I agree. Mark Sanders put up best discussion we've had in the series. It's awesome. It's great that we had a discussion back and forth with 90 of us is really great. So thank you all for participating so much through the Q&A. Mauricio, thanks for the great case. Thought we'd get to more, but I'd much rather do this. If you want to come off of your share, I'll go back just really quickly to the closing slides.
Thank you.
And get that going real quick. So again, we noted the recurring themes, and I'll go past those real quick, and just want to point out to everybody again, if you go up onto the aona.org, you'll see the osteotomy weekly lineup, and also on YouTube, really phenomenal jobs been being done by the folks doing this course, and Michael Sorkin's been doing the lion's share of the YouTube stuff, if not all of it. And I'll tell you, it's a treasure on YouTube if you go and take a look at it. Amazing amount of work, but a really high quality. So you'll see the different lectures broken out one at a time if you want to just go watch one from our May 30th, for example, or the whole thing together. It's really an amazing educational feature that's up there on the AONA YouTube page. Please register for each event, because then you can get the credit and all of that. On Saturday, we're going to have a small group discussion. We're doing this one different. It's going to be just like this one. It's going to be one big group with all of us talking together. And in this one, our intention is to have each of the faculty present a case they did themselves, so that we really can give you the reasoning behind what we did. So I think it'll be fun. I think there'll be 4 cases. Hopefully we'll get through all 4. If we don't, I'll do mine last. And so you can hear from the real masters first, and I'll not if we don't have time. And then we'll kind of go from there. There's going to be on June 11th, then a final Ask the Experts, where we'll do a bunch of other cases, and then we shift over to tibia on the 13th. Again, there's a link to the recording that'll be sent out through Zoom 24 hours after the conclusion of this webinar to all of you who registered. So another reason to register. And you can access that through YouTube AONA, AO Trauma North America channel. And the playlist is the osteotomy course. So again, this is kind of our final slide. I think that we do this because we have a passion for treatment around the knee. So right now we're putting up a quick evaluation of this session. If you guys could take just a second to fill that out, we'd greatly appreciate it, rating the overall experience here. And again, thank you all so much for joining us and for participating so much. It makes it really much better education when we all participate with each other. So thank you.